Okay, so welcome everyone, and thank you for joining us for today's session on frequently asked questions on multiple myeloma precursor conditions in the Black community. I'm Mary Jerome, Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. I am joined today by Dr. Craig Cole from Michigan State University in Lansing, Michigan, and also Ms. Amy Peer from Memorial Sloan Kettering Cancer Center in Montvale, New Jersey. And thank you so much for joining us, both of you. Really appreciate your time. They've been gracious enough to agree to spend some time with us today to answer some of the frequently asked questions we receive from Black patients and caregivers about the myeloma precursor conditions, MGUS, and smoldering myeloma. So let's just jump right in. And I do want to say that if people have questions that they would like to ask, they can certainly enter questions in the comment box, and we will hopefully have some time at the end to be able to address some of the patient questions that come in today. So our recent webinars on this topic have revealed that the Black community is at higher risk to develop a myeloma precursor condition, and that multiple myeloma is twice as common and twice as deadly for Black patients compared to white patients. So, Amy, I'm going to start with you on this. Can you walk through what a myeloma precursor condition is and tell us why Black individuals may be at higher risk for developing these conditions? Specifically, is this risk only for Black individuals who are in the US, or do people of African descent who grew up elsewhere, for example, in Canada, have the same level of risk?
These are really great questions. And first of all, Mary, thank you. I want to thank the MMRF for giving us time today to address these really important topics. So I'm really grateful to be here. There is a precursor condition to multiple myeloma. It's called MGUS, or monoclonal gammopathy of undetermined significance. This is when patients produce that abnormal monoclonal protein, but it's not really bothering them or causing any sort of problems in the body. This precursor condition does not require treatment, but rather just active surveillance, as there's a chance, a very small chance, it can transform into multiple myeloma. Now, the risk of transformation, give or take, is about 1% per year, some more, some less, depending on the risk stratification of that MGUS. And there's also smoldering myeloma, also known as asymptomatic myeloma. These patients tend to have a larger percentage of this abnormal plasma cell in their bone marrow, and they can produce a larger quantity of that abnormal monoclonal protein as well. But again, there's no evidence of what we call end organ damage with these patients. And the risk of transformation is a bit higher in these patients, so they're followed a little bit more closely, usually every 3 months. And there's also a high risk form of smoldering myeloma, meaning these patients are very highly likely to transform in a short period of time. And those patients are eligible for treatment to decrease their level of myeloma, usually on a clinical trial. Now, there are studies that have shown that Black patients are 2 to 3 times more likely to develop these conditions compared to whites. Mm-hmm. And this risk has been seen really across the world in Black individuals of African descent, Caribbean descent, and Black Americans. So this really transcends across geographic location. Mm-hmm. Mm-hmm. And we know that there's an ancestral or an inherited predisposition to these diseases, as having a first-degree relative with myeloma can increase your risk of developing the condition by close to 90%. And if a Black patient has a first-degree relative with myeloma, it increases their risk of developing the condition 5-fold. And we really know this to be true, as we do see in practice relatives of myeloma patients having more MGUS. And because of these facts, it's really important for Blacks to share their family history with their healthcare providers so they can be monitored for the development of these conditions.
Mm-hmm. Do you have anything to add, Craig, to that really great explanation of myeloma precursor conditions and the risks and what might potentially cause those higher risks in the Black community?
Sorry about that. Well, again, it's great to see Amy, and it's great to see you again, Mary. And thank you to the MMRF for really talking about this and bringing this to light. And so, because the more awareness that we have about myeloma precursor conditions, especially in the African American community, because just like Amy had said, that it's more prevalent in our community. But I think that, in addition to what she said, there there is a pre-symptomatic part of myeloma where the risk is so high, it's over 90%. In 2 years that we do treat those folks. And those are folks that have the folks that have the slim crab criteria. And in 2000, I think it was 14 or 15, the International Myeloma Working Group met and said that these folks that have bone marrow plasmacytosis of greater than 60%, people that have abnormal light chain ratio of greater than 100, and people that have more than one lesion seen on an MRI or sensitive scan have such a high risk of developing symptomatic myeloma that we actually treat those folks. And so what used to be called ultra high risk is now called slim crab. We treat those people outright. And so now we're left kind of with a group of people that have, true smoldering myeloma, asymptomatic disease. And so, but yeah, I think it's really, really important for folks to know about this condition and their family members.
Right. So along those lines, how can patients know that they have a myeloma precursor condition, right? So many times these conditions are asymptomatic. So people may have them for a number of years and not really know that they have them. So are there any physical symptoms that people may experience that might lead them to believe that they have a myeloma precursor condition? And are there things that would be basically just pop into their mind, like, oh, I'm having this feeling, I'm having back pain. Maybe I should go to my doctor and talk to my doctor about the possibility that I might have multiple myeloma. So can you talk to us a little bit about those types of signs and symptoms? Because I think that, for these precursor conditions, they can be really diffuse signs and symptoms and can be confused with other conditions, so that people really need to be aware that this, along with other things, is also a possibility when you have these certain physical symptoms.
Yeah, absolutely. And the classic, asymptomatic by definition means I don't have any symptoms. Oh, well, what do you define as symptoms? Well, classically, we've defined myeloma symptoms as is using the CRAB criteria. Hypercalcemia. So how do you know if you're hypercalcemic? Well, if you don't have a lab, right at your in the kitchen. People that have high calcium levels can feel fatigue, they can have confusion, and they can urinate a lot because their bodies are trying to get rid of all that calcium. Renal, the R stands for renal insufficiency, so for low kidney function. How do you know if you have low kidney function? Well, it's not so how much what your urine quality is, it's how well your kidneys are clearing those bad proteins, those used up proteins in your body. So again, that's confusion, weight loss. Some patients will say that they have foamy urine, that they flush the toilet and the foam won't go down the toilet. And another is anemia. A stands for anemia, and when your hemoglobin's low, that's primarily people feeling fatigued, short of breath. The whites of their eyes or their mouth can be really pale inside. And B stands for bone disease. And again, when people have bone disease, they can again have fatigue, but primarily pain. And pain, like you said, in the back, pain in the arms or legs where the myeloma can move there. But the common thread between all those symptoms is fatigue. And so, and I would say that when an African American, this is what I tell the people in training here, that when an African American walks in that has kidney problems or has new back pain, myeloma should be on the list because you need anytime you do a test, you need a pre-test probability. How likely is this test to be positive based on what I'm seeing? People of Asian descent have a very low risk of myeloma. So if an Asian person walks in with low kidney function, I wouldn't necessarily, check them for a precursor condition. I would look for other things that are more common in the Asian population. If an African American walks in, and I know it's 2 to 3 times more likely for them to have myeloma, my pretest probability is higher. Therefore, I should check it sooner.
Yeah, right. So, and I always think about anemia as well, right? Because that can be caused by any number of different conditions, right? But, I think it's important when, especially a Black patient is diagnosed with anemia, to ask their doctor, why am I anemic? Am I iron deficient, or is there some other reason that I'm anemic, right? And that might lead to something. Are there other things that myeloma patients might experience, or precursor patients might experience, like neuropathy or osteoporosis, that might be related back to their precursor conditions?
Yes. One precursor symptom are recurrent infections. And I had kind of forgot to mention that earlier, that because myeloma is a cancer of the immune system, when people have cancer of that immune system, they are more likely to get infections, especially bacterial infections. So, there's some people talk about the crab eye, where the CRAB and the little case I, meaning recurrent infections. Also, just like you had mentioned, neuropathy. So a neuropathy isn't an end diagnosis. When people have neuropathy, it's due to something.
Right.
And sometimes that extra blood protein, that monoclonal protein, especially the light chains, can settle in the nerves and cause nerve damage. So if you have neuropathy, ask your doctor, what is my neuropathy from? Is it from condition A, condition B? If they say, I don't know,
Right.
then I would really, I would make sure to check for a monoclonal gammopathy.
Oh, sure.
But definitely,
Yeah.
in 1844, the first person that ever was described to have myeloma, the thought was that she had osteoporosis, and so that weak bones or breaking of the bones, and unlike 1844, we have much better tests today to be able to say, is this truly true osteoporosis, or is this a disease that goes to the bone and causes bone destruction like myeloma? And one test that can help distinguish those two is the PET scan, which is a super nice, sensitive test to be able to pick up bone disease that can discriminate between this regular old, a softening of the bones like osteoporosis versus something more malignant like multiple myeloma.
Right. So, and I always, it always is interesting to me that, this sort of deposition of items or, substances at nerve endings. I mean, this can also happen for people, obviously, who have diabetes, right? And in that case, it's this excess sugar that's in their bloodstream that gets deposited in their nerve endings. And that also causes neuropathy. So again, this is another thing. If I have, like you said, if you have neuropathy, you need to ask your doctor, why? Why do I have it? And so then getting back to, determining why you have anemia or why you might have neuropathy. Let's talk about screening people for precursor conditions. So right now, screening is not done on a regular basis, right? Like it is for breast cancer or colon cancer.
Yeah, it's not, but there are some really strong arguments. I'm smiling because I love talking about this. I think that should right now the iStop Icelandic study is looking to see what if you screen the entire population of Iceland. The one thing about that study is that there are not a lot of people of African descent in Iceland. So I think that we'll get some information from that. But really, should we be screening, people for myeloma precursor conditions? And I would say that, and an argument has been that in the correct group, what would that correct group be? Well, people of African descent over age 50 have a higher risk of having, a myeloma precursor condition. And especially if they have more than one family member that has a plasma cell dyscrasia or a plasma cell cancer. So if they have more than one or more family members and they're Black, then the chances of finding this, again, the precursor, the pretest probability is higher. people of any ethnicity that have more than 2 family members that are affected by myeloma or myeloma precursor condition also, I would say, could be screened. And if you look at that group, your chances of finding a plasma cell dyscrasia, we think, is about 25%. So it's worth screening in the same way that we screen people for colon cancer because I have a primary family member that has colon cancer.
Right.
You know that we should screen for these because me too. Because if you can find one of these precursor conditions, not only is it important for research purposes for us to have a better understanding of how this works, but I always tell my MGUS patients from now on, you should never ever have a broken bone or going to renal failure with myeloma. It'll never happen because we're going to monitor this protein level, and you should never ever have anything bad happen to you because now we have the knowledge to be able to know if anything changes. Because the fortunate thing about these plasma cell dyscrasias is that the higher the risk, the higher the protein level, or the higher the protein level, the higher the risk. So we can do risk assessment right away. For colon cancer, you really can't do that. I mean, we don't have a good way to determine risk. It's kind of an on or off kind of thing. But for these, you can monitor through time to see if anything changes.
Right. And there are a couple of studies ongoing that are doing just that, right? That are really coming out of the Dana-Farber Cancer Institute in Boston. So, I mean, there's the P-Crowd study and the PROMISE study. So can you talk a little bit about those 2 studies?
I love the PROMISE study. I am a PROMISE study member.
I'm trying to be a PROMISE study member. So I signed up.
Enough.
I haven't gotten it yet. I'm waiting. Oh, but my mom had multiple myeloma.
Oh, really?
Yes.
Oh, I didn't know that.
And that's not a well-known fact, but she did have multiple myeloma.
Oh, wow. I didn't know that.
Yeah.
But yeah, I signed up. And so for people that have primary family members with myeloma or people of African descent over age 50, they can sign up for the PROMISE study, which is much like the iStop study in Iceland, but it is in the United States. And of course, it is because it screens Black people and people of African descent, it's going to enrich for the people that really, the patients that have a higher likelihood of having it. Instead of screening everyone, it looks for a higher risk group. And you can go to a local lab, or you can really go to any lab, get the lab testing done. They test you for the precursor conditions. And you fill out a form online that describes a lot of really important questions and demographics. It's all super, super secure. And if you don't have a myeloma precursor condition, then you get retested in about 3 years. And if you do, then you refer to a specialist, and then you're also followed along. So it's a really good, very good study that I love the PROMISE study because it's going to give us some, the number one question I get is, why does this happen to Black people?
And this is what we need to find out, right? I mean, these studies will be really, really helpful. And I just saw the other day that they've now enrolled over 5,000 patients in that study, which is really, really awesome. It's a great number.
20% African American. And that is exactly the number. If you look at all myeloma patients across the country, that is exactly the number of African Americans that are affected by myeloma. But we need to get, that number enrich that population as much as we can.
Absolutely. Absolutely. So, and then the P-Crowd study is actually a study for people who have already been diagnosed with smoldering, I believe, right?
Yeah.
Okay, then that's another good study that's coming out of that area. And then I just wanted to put in a little tiny plug for the MMRF Cure Cloud, which is also accepting certain patients who are enrolled in the P-Crowd study. So, look at that little, look at that nice little card that you've got there, Craig. Good job.
Right on my desk. So.
So I encourage anybody who is a smoldering patient, if you're interested in joining CureCloud, you can join the PCrowd study. And if you're eligible, you will get a code and you can certainly join the CureCloud study. And then that will enable you to have your genomic testing, et cetera, and then, having your information de-identified and added to the CureCloud database, which again is a helpful way of being able to do the research to determine who is going to get this disease, who is going to progress from precursor to full-blown myeloma. The data is what we need to be able to determine those things. And it's so super important, super important. So Amy, so I know that precursor conditions can be confused with a number of other syndromes, conditions, or diseases that are prevalent in the Black community. But are there symptoms of precursor disease that are similar to symptoms that you might see from, for example, sickle cell disease or kidney stones?
Sickle cell disease usually manifests as anemia, and there's usually a very painful syndrome associated with that.
Mm-hmm.
And kidney stones, of course, are excruciating back pain. But it's very easy to diagnose both of those things. You can do a hemoglobin electrophoresis to understand if someone has sickle cell disease. Usually a little bit of family history. There could be some family members who carry that trait. And kidney stones are pretty easy to see with imaging, right? But I would say you can have a monoclonal protein that has nothing to do with the precursor condition for myeloma. For example, you could produce a monoclonal protein in connection with a rheumatologic condition like lupus or even, rheumatoid arthritis or psoriatic arthritis. And you could even produce a monoclonal protein related to infections such as hepatitis C or even HIV, or sometimes even very rare bleeding disorders like von Willebrand's disease. You can produce a monoclonal protein. And I've even seen in my lymphoma patients produce a monoclonal protein kind of directly related to their lymphoma. But I do want to say that signs of myeloma can be confused with other disorders in the Black community.
Oh, absolutely, sure.
So, for example, multiple myeloma can cause kidney damage or peripheral neuropathy, as we talked about, as a direct result of these abnormal monoclonal proteins depositing on the kidneys or the nerves. And healthcare providers may think that kidney damage is related to, hypertension, which is commonly seen in the Black community, or they may see the neuropathy and think that's more linked to diabetes, which is commonly seen in the Black community. So our patients really must be ready and armed to ask questions and actively participate in their care to make sure that the understanding regarding certain medical conditions are properly and accurately diagnosed. And just like we talked about, understanding what's causing that anemia and truly understanding what's causing that renal insufficiency is important.
Yes. So, I mean, certainly it's great for people to be able to advocate for their own care. So to be able to do that, patients really need to know what the signs and symptoms of myeloma are, and then discuss the causes of them with their doctor when they're in the office with them, right? So it does seem like it's a lot of work on the part of the patient, but people go through this same exercise when they're buying an appliance, right? You're not just going to go to the store and buy the first one you find, right? You're going to look at the reviews. You're going to understand what you need. You're going to make sure that the appliance you want to buy has the characteristics that you want. You're not going to walk in, the salesman's going to say, oh, you want this refrigerator over here, right? You actually know what you want when you enter the store. And this is, what is being a consumer of your healthcare means, right? You have to walk in with knowledge. And if you do that, then that will certainly give you a more positive outcome than walking in without any knowledge at all with that. So Craig, if a patient has been newly diagnosed with myeloma precursor conditions, what is the first thing that they should do? Is if they've been diagnosed with MGUS or with smoldering, is it inevitable that they will eventually progress to full-blown multiple myeloma? And often patients ask if they've been diagnosed with MGUS or with smoldering, and you did mention this earlier, are there treatments that they can take that can actually prevent progression of people who are at risk? And talk a little bit about the risk assessment of people who specifically have smoldering multiple myeloma and what that might mean for their care plans.
Story of my life, unmute. So, when it comes to, when you're first diagnosed with a myeloma precursor condition, the first thing to make sure of is, as we talked about earlier, are you sure it's not a symptomatic myeloma? And I think that the, one little fine point is really making sure to get a PET scan, because the skeletal surveys that we've been doing, or just the bone x-rays that we've been doing since 1900, is a okay screening test, but the PET scan is a much better way to pick up bone lesions from a symptomatic myeloma that needs treatment outright. So after that, then the question is risk assessment. So we had been talking about earlier, and as you had mentioned, does everyone with MGUS or smoldering myeloma destined to get multiple myeloma? No. However, we're able to better define that risk of who is more likely to get it by using some of the risk assessment tools. So MGUS has a risk assessment tool. So if you have MGUS, the questions are, what's the light chain ratio? If the light chain ratio is abnormal, then there's a little bit higher risk MGUS that could turn into something bad. If the M protein is anything other than IgG, is a little bit more risk. And if the protein level is real high, greater than 1.5, like Amy had mentioned, then that risk is a bit higher. But all in all, if you get all patients with MGUS, the risk is about 1% per year. If you have smoldering myeloma, there are also risk assessment tools for smoldering myeloma. And the new favorite is the 2220. That is really, is not only a clinical tool, but also a research tool, where it is, the 20 stands for a bone marrow plasmacytosis greater than 20%, M protein greater than 2, and light chains greater than 20. Pretty easy to figure out. And if you have 2 to 3 of those 2220s, you have about, in 2 years, of about a 46% risk of developing a symptomatic myeloma in 2 years. If you have high risk cytogenetics on top of that, then it's about 60%. And so when I see a patient that has smoldering myeloma after you've done their bone marrow cytogenetics, I start with the 2220. I use that risk assessment tool. There's a fine-tuning tool that is also there, the International Myeloma Working Group 2019. It's a 20-point assessment, and that can fine-tune it a little bit more. And then we follow over time to see if someone has evolving type smoldering myeloma. And that's defined as the M protein is going up and up and up by 10 to 25% over the course of 6 months to a year. And is their hemoglobin going down? And if the hemoglobin is going down, the protein is going up, and they got greater than 20% plasma in their marrow, that is evolving type smoldering myeloma. And that actually, I think, is a very important tool, because those folks have, close to 80% chance of having symptomatic myeloma in 2 years. And so that evolving type are the ones that I really, really kind of think about, should we treat or not? All the other types, I think, are really best served in clinical trials, because the fact of the matter is that we need better clinical trials, especially in people of ethnicity, to understand not only the natural history, the risk factors, but how can we best tackle this disease, where not everybody is the very high risk. But what can we do about the intermediate risk, people, where most people, both in MGUS and in smoldering, would be low to intermediate risk. That's what we really need to concentrate a lot of research on, to be able to intercept these diseases better.
So just thinking about, patients who may be at intermediate risk, right? Or really any patient who's been, who is having these symptoms. And I hesitate to say diagnosed with precursor, because it's really, diagnosis is difficult, right? So, how well do you think patients or doctors who are not hematologists or not, specialists in hematology oncology, how well versed do you think that those doctors are in recognizing the symptoms and that they might be due to myeloma? And when do you think patients who think that they might have a precursor condition, when should those folks be seeing a myeloma specialist or at least a hematologist oncologist?
I think everyone, because there's so much happening in the smoldering and precursor area, more so than I've ever seen in my career. I mean, it's really, really,
It just
really,
has exploded in the
it
past couple
has
of years, right?
exploded.
So much stuff going on, which is great.
Goodness.
Yeah.
It used to be that 6% of all myeloma publications was on smoldering. And that is just, changing.
Mhm.
And there's so many, new things that are happening. I would say everyone that has smoldering really should get a second opinion with a myeloma doctor. And especially if someone's considering, their primary doctors are considering treatment, that is and I would say the bulk of our smoldering second opinions. In fact, I would say the bulk of our second opinions are actually smoldering and precursor conditions right now.
Interesting.
And really because it's evolving so quickly, and a lot of primary hemonc people just is to treat breast cancer, colon cancer, lung cancer, and this area is so difficult for those primary hemonc people that they really want their patients to see a specialist that only kind of dives into this area. And I would say that and I've done lots of grand rounds at different hospitals about the myeloma precursor conditions and MGUS, because the one feature that we had mentioned earlier is that to have MGUS, you have to be absolutely certain that there aren't any other conditions that can be attributable to MGUS. The neuropathy, the bone pain, the high calcium, the kidney function, and the myeloma specialist can really help with that.
Right.
And so I would say, if you're a high risk MGUS, if you're any smoldering, you should definitely, think about a second opinion with a myeloma provider to try and help educate, sort things out in potential clinical trial.
And some patients.
Go ahead, Amy.
Oh, sorry. I was going to say, some patients think they're seeing a myeloma specialist because they're seeing the general oncologist in that practice that sees the majority of the blood cancers. So it's really important to ask questions and see, how many myeloma patients do you see a month per year?
That's such an important question with this field, because as Craig mentioned, it's so rapidly evolving and there's so many new things happening that, in order to have the best outcomes, you really need to have a doctor who sees a lot of patients and is really very well versed in this disease. Absolutely.
Studies have shown that patients who do see a myeloma specialist or an oncologist that has a high volume of myeloma patients, those patients do better overall.
Sure. So let's talk a little bit about the trials that are available, clinical trials that are available to patients who have smoldering, high-risk smoldering disease. So Craig, I'm going to start with you on that, but I'm going to move over to Amy afterwards to get her opinions as well. So what can you tell us about that?
Oh boy, here. I hope Amy and I don't fight. So we'll.
No, why would you fight?
So
we can never fight.
Oh, never. So so there have been two trials on treating high-risk smoldering myeloma. One is the Spanish trial that was done years ago that got patients with smoldering, thought to be smoldering myeloma back then, and treated them and saw a lot of positive outcomes. However, some of those folks, they didn't have the sensitive scans that we have here today. So it probably contained some myeloma patients, some true myeloma patients in the observation arm that was with that trial. In the United States, there was the E3A06 trial that had patients either receive Revlimid or observation, the standard of care. And there's some tricks about that trial. It was important in that it showed that giving Revlimid to smoldering patients did decrease the incidence of having symptomatic myeloma, the transformation symptomatic myeloma. However, that study, the number of people that actually had a benefit, the high-risk patients, was only 53 patients. I mean, it was a very small number of patients that actually were the benefiters. And if you look at the number of people who were on that trial that left for some reason, the number was not insignificant. And so I think what it taught us is that, yes, being on a clinical trial and investigating smoldering myeloma is really important. It has positive outcomes. However, do we have enough data to really generalize that for that to be a standard of care? I don't think we have enough data for that to be a standard of care. I see Amy nodding, so I think we're not going to fight today. So I guess today's not the day.
But, no debate for me here. I 100% agree with what you said.
And so I think that there is, there are some trials that show promise, but I think that we need better studies. The good thing is that, according to cancer.gov, there are 76 ongoing trials for smoldering myeloma at this time.
Yeah, there's a lot of them out there, right? And so I know that every year we've started doing this precursor condition, like smaller meeting, and learning about all of these trials that are ongoing. And they run the gamut from right now it's like the for the high risk smoldering folks, it's really Revlimid with Dex, right? But they have trials that are ongoing with things like isatuximab, Sarclisa or Darzalex. And they also have some other trials that are actually the quote unquote curative trial, where they're really, giving some very aggressive therapy to smoldering patients and just really, following them to see what happens with their disease. So these are all trials that are much more in their earlier phases, and we don't have readout on the data yet compared to some of these other ones that we've been talking about. So it'll be really very interesting to see how some of these trials actually read out, as the data comes in. And hopefully we'll hear more about that at the upcoming ASH meeting in December and other subsequent meetings as well. So there's a lot going on. So Amy, what can you tell us about your experience with clinical trials in smoldering?
I would say that we do need more data, more like longitudinal data, and more patients enrolled, because these small numbers, it's hard to truly extrapolate. And I don't think we've figured out exactly who are the smoldering patients that require XYZ treatment at what period in time. Once we figure that out, we'll be able to know exactly what to do, but it's going to take a little bit more time and more studies and more people to be involved and enroll in studies. A lot of patients are not comfortable with the watch and wait strategy with smoldering myeloma. And so this is a way you can actually maybe have a more proactive approach in your care and seek out a clinical trial that may offer you treatment.
So Amy, along those lines, right? So we've been talking about really a lot about the high risk smoldering patient who really has a higher chance of progressing faster than patients who may be at intermediate risk or low risk. And certainly there's some patients in the Black community that may have had smoldering myeloma for 10 years and have been relatively symptom free. They've been undergoing, regular monitoring. Nothing is changing. So these patients who are sort of in steady whether they should join a clinical trial or a screening study, or is it if their likelihood of developing myeloma at this point is so low since they've been smoldering for such a long time, is that type of involvement in a clinical study at this point unnecessary?
Yeah, they say the longer you smolder, the more likely you will continue to smolder. So it's a good sign remaining in that stage for such an extended period of time. But it's really never unnecessary to explore and pursue other options for your medical care, right? I always push my patients to be inquisitive, ask questions. I want them to participate in their medical care. So clinical trials and screening studies are how we learn and how we help our patients. We want to do better than what we did 5 years ago or 10 years ago. Or what did you say, Dr. Cole? 1800s?
1844.
want to do better than that. And we can only really do that by learning and growing, right?
Mhm.
So
Mhm.
patients with these precursor conditions could be eligible for clinical trials that could treat these conditions, decrease their level of these monoclonal proteins to a level that may be completely undetectable. What if that's a functional cure? Wouldn't that be exciting?
Mm.
We would only know this if we study and treat these conditions.
Mhm.
Because we know that Black patients are at an increased risk for developing these precursor conditions, participating in a screening study may allow us to catch these conditions earlier, as Dr. Cole was saying. If you're found to have this condition, you can recommend family members to also participate in screening studies because we know that they're also at a higher risk. It's much better to arm yourself with knowledge and
For
be
sure.
proactive about your health and your care.
Mhm. Mhm.
I think a lot of people are scared and think, I've been told that myeloma is not hereditary. I can't pass this down from generation to generation. It's a little bit different than hereditary breast cancer, right? We've
Mhm.
identified the BRCA gene.
Right.
We know that's hereditary. You can pass that down from generation to generation. We haven't found a magic gene like that for myeloma yet,
Mhm. Mhm.
but there's something there. The
Mhm.
fact that Blacks are more likely to develop myeloma, more likely to develop MGUS, and also when you're looking at the strict genomics of the myeloma, there's certain chromosomal abnormalities such as translocations that are more common in Blacks than other ethnic groups. So there is some sort of ancestral component to myeloma that we don't fully understand.
Right.
And plus the fact that first degree relatives, there is a slight increased risk. But again, myeloma is rare. It's only 2% of all cancers. Dr. Cole and I feel like everybody has myeloma, but actually that's not the case.
Not the
It
case.
is rare,
Mhm.
but you do need to understand your risk is higher if you are Black and if you have a first-degree relative.
Mhm.
So
Mhm.
it's important to ask questions and make sure that you're being looked at appropriately.
Good question. So now getting back, Craig, to the patients who are not comfortable with watching and waiting, right? Which used to be like that was basically all you really had for a really long time. If you had precursor conditions, there was really no treatment that was given. It was just monitoring and what they used to call watchful waiting, right? To make sure that if something changed, then you would begin to think about what was going to happen next. But sometimes patients really feel that weight on their shoulders, right? That they know that something's happening and they're waiting for like the other shoe to drop or something, right? So these patients, some of them would just really rather do something than do nothing. So if these patients are a low risk smoldering or an intermediate risk smoldering, not a high risk smoldering patient, but more of a low to intermediate. So can those patients actually be treated on a clinical trial? And what kinds of questions should they be asking their doctor about, being on a clinical trial? What is their risk of progression? What are the risks of early treatment? Talk about the annual blood work that they have done and the review that their doctor does on their blood work and how that might impact their care plans.
Yeah, everything that you said, of course, was correct. But if someone wants to, the good thing about having 76, clinical trials that are out for smoldering myeloma is that there's a menu. And so the clinical trial that we're opening at MSU in smoldering myeloma, there and it's really kind of the classic new 2021 clinical trial for smoldering is that it is a randomized trial, but the treatment arm is 2 drugs, including Revlimid, and the observation arm is Revlimid. And well, why is that? Well, because some people, have a fear of randomization to complete observation. And so if someone wants treatment for smoldering, I would strongly recommend that treatment be done in the context of a clinical trial. So we learn more. I mean, not only does that give you treatment, not only you get the benefits of treatment, but you also get the benefits of very close observation in a clinical trial. You have a research nurse, a clinical nurse, a research doctor, a clinical doctor. You have a whole army that is watching any symptoms, signs that you may have that is addressed very quickly. And so it is just especially in a disease where we're starting to get an idea of what the risks and benefits are, to have that in the context of a clinical trial is really, I think, preferable. And the good thing about the clinical trials these days for smoldering is that the requirement criteria have really opened up quite a bit. It used to be that we're only going to look at that high risk group. Now they're saying, well, we need to open that up a bit because that helps us learn more and that helps patients more. And so if a patient says that they want to be active and they want to actively participate, there's no greater way to actively participate than to be on a clinical trial. For it benefits you, it benefits your family, it benefits your extended family, and it benefits everyone in the smoldering and myeloma world for us to understand better how best to treat this.
Right. So more data is always better, right? And so the more data that you can collect on patients, that's certainly de-identified, so it's not traceable back to the patient, but it's all collected, aggregated, and then researchers are able to look at that data and really try to tease apart what the qualifications are of a patient who has gone from smoldering myeloma to full-blown myeloma, genomically and clinically, so that you'd be able to predict these people, predict that progression earlier and then, treat earlier.
Absolutely. So the answer to the question that you asked me about what should a patient with smoldering ask their doctor is there a clinical trial or research study available for me? I would say most myeloma centers out there right now have a clinical trial on smoldering because it's such an important issue. It's such an important issue for African American patients, patients of African descent, and everyone.
Did you have anything you wanted to add to that, Amy?
Oh, I was just going to say, when you're talking about we need more data, this is a scenario where more means more. We actually do need more data. We actually also have a trial for high-risk smoldering myeloma patients with isatuximab. You're eligible if you have high-risk smoldering myeloma that hasn't been treated, that you can walk around and do routine activities of daily living, and you have to be an adult. Those are pretty much the only eligibility criteria. The plan is to, prevent or slow down the development of myeloma with studies like this. So just like Dr. Cole says, if you have smoldering myeloma, the first question you should ask is there a clinical trial that's here for me? And if there isn't, can you point me in the right direction where I may be able to find one?
Yeah,
exactly.
Because the majority of our patients are treated in the community, and the community practices may have limited trials. So they should be referring you to centers that do have more trials available if they're unable to offer you a trial.
That's such good advice, really. So I've been just looking through the comment section and looking at some of the comments that people have written in. And I have to say that the vast majority of the comments are around the hereditary or not nature of multiple myeloma. So there's many people writing in saying, my mother had it, her sister had it, her brother had it, or some people writing in and saying, I just have one first-degree relative who's been diagnosed. So, the question is it hereditary or is it not? And if you have a one relative that has myeloma, how much different is your chance of getting that disease versus somebody who has, 2 or 3 primary relatives that have multiple myeloma? Amy, I'm going to go with you first on this one.
Yeah, it's a great question. I think Dr. Cole did outline some of those statistics earlier about having a first degree relative or 2 family members. And we do know that we don't know that there's an actual gene, like the BRCA gene for breast cancer, for example, that can be passed down from generation to generation. But we do know there is some sort of ancestral component to myeloma, the fact that there is an increased risk with having a first degree relative, and there's an increased risk of developing myeloma if you are Black. So there is something to it. We just don't fully understand what that is. We haven't mapped it out in the genome yet, but there is some sort of ancestral component. So if you do have a first degree relative, I think it's important to let your primary care provider know this. And if you want to participate in screening trials, there's many that you can participate in that Dr. Cole mentioned.
Yeah, I would say that years ago, I'm going to take a guess at maybe 10 years ago, the belief at that time, really because there was a paucity of data on African Americans, was that myeloma wasn't hereditary. And so that was kind of the old, from 10 years ago statement. I think that more recently, in the past, especially in the past 7 to 5 years, when we've had more African American patients involved in clinical trials, we now know that saying that it's not hereditary isn't the truth anymore. I mean, that has evolved with everything else, that we know that. And actually, and part of the reason is that there have been studies that have seen that African American, the hereditary pattern of myeloma in African Americans is greater than it is in Caucasians, meaning that being African American, having a primary family member that has myeloma puts you at a bit higher risk than if you're a Caucasian and having a primary family member.
Right.
Why is that? We don't know, but that's why we have the studies ongoing. Is just like Amy said, there's something deeply ancestral about this. When you look at the different ethnicities and the different races, the reason that they're different races is because there have been different immunologic challenges to people that lived in Northern Europe versus Africa versus Asia. And somewhere in that difference lies the key to this disease. And the way to figure out myeloma, not only for African Americans, but for everyone, is to figure out what's that key, to find that BCR, that BCR-ABL, that BCR, because I'm a hematologist, not a breast cancer doctor, or BCRA1 or whatever that gene is. I don't know what it is. Find that for myeloma.
Yeah.
Somewhere deep in the genome.
Yeah. It would be nice if it was as easy to be able to track it back to one gene. Somehow, I think that if it was, we would have found it by now. Excellent. So we'll see. It could be definitely more complicated than that. But Amy, I wanted to get back a little bit to what you said about the your risk of getting myeloma if you had a family member who had it, right? So if you have a family member, like maybe one family member who has myeloma, I think that your risk, so you said that it was like your risk of myeloma was 90% higher, right? If you have a family member but that doesn't mean that you're 90% more, you're 90%, you're going to get myeloma versus 10% you're not. That's not what it means, right?
No. And thank you for clarifying that. That's not a 90% chance you're going to get myeloma. No, it's just it's an increased risk by 90%.
Right. So it's more like maybe you have a twofold higher risk of getting myeloma, right? If you have a family member who has myeloma. And because the risk of having myeloma is so small to begin with, it's really only 2% of all cancers. That a doubling of that doesn't really put you at a hugely higher risk. It's somewhat higher, but it's not hugely higher.
Exactly.
So, but it's still certainly, something that bears watching. So, as we've been mentioning. So a lot of good questions on here. Okay. So we're getting to the end of the hour here. So I'm going to ask one more question, and maybe we'll have some time to dig through some of the ones that are coming in on the comments. But so both of you, we've been talking about clinical trials that might be available to patients who have MGUS or smoldering. And historically speaking, participation in clinical trials in the Black community has been low. And we know that there are all sorts of reasons that are very good reasons why there is underrepresentation of Black patients in clinical trials, from well-earned suspicion from the Black community based on abuses that took place and still are taking place in the health field, and disparities in care, mistrust in the medical establishment. So if you have a Black patient who has a precursor condition and comes to you and talks to you about considering a clinical trial, what are the types of things that you would say to them to maybe, make them feel a little bit more comfortable to enroll in a clinical trial, and really the value of that? So Amy, I'm going to start with you on this one.
Yeah, first of all, I think it's incredibly important to acknowledge that there truly is a level of fear and myths and mistrust in medical professions, given the historical and unfortunate marginalization of minorities in this country by the medical community. So when discussing a clinical trial with my patients, particularly my patients who are Black, I want them to have an open and candid conversation about what their fears and concerns are about participating in a clinical trial in general. I want to make sure that all their questions are answered, and I want their loved ones who are also instrumental in their decision making to also be involved and informed and their questions answered as well. It's really important to take time with patients. Sometimes consenting a patient for a clinical trial can take multiple visits, which is completely fair. You're asking your patient to consider participating in a treatment plan that might be possibly outside of standard of care. Usually it could be an augmentation of standard of care, but patients may think you're truly experimenting on them. So make sure they understand the risks and the benefits and exactly why you are recommending this trial for them and why they're an excellent candidate for the trial. You have to demonstrate that you're recommending the trial for their benefit, not your benefit. It's about providing the best care plan, the optimal care plan for them, because a clinical trial a lot of the time can afford patients the opportunity to participate in novel and promising therapeutics. So make that clear and provide the time to make that clear. And also make it known that it's perfectly okay for them not to participate, but make sure they're deciding to not participate in the trial for the right reasons and not misconceptions.
Craig, anything to add to that?
Excellent. I mean, every word was poetry. But I mean, absolutely. And I think that, and the other thing I would kind of add to that is that there is no safer time to be involved in a clinical trial than it is right now. And the multitude of safeguards that for a clinical trial has to go through in order to get to a human being is enormous. And it makes, and having done clinical trials for 20 years, it is absolutely the safest time to do a myeloma trial in 2021, because there's so many safeguards and there's so much good therapies out there, and there's so much thought that has gone behind them. But the number, in order for a clinical trial to see a human being, it has to go through multiple FDA checks, multiple checks at the local institutional review board, protocol review committees. I mean, only the cream of the crop actually sees a patient. And really, it's the most safest trials, especially in precursor conditions. Only the safest trials actually are the ones that enroll patients. The other little quick thing is that, of FDA registrations for myeloma trials, only, 5.4 of those trials had African Americans in it, which means, there are 20% of the myeloma population is African American. But the clinical trials only had participation of 4.5%.
Right.
So we need to make sure that these drugs work for African Americans, because there are biologic differences. We've talked about a lot of those differences. We need to make sure these drugs work. The way to make sure they work is involvement in clinical trials.
Amen.
Amen.
Can I just say the lack of diversity in oncology clinical trials is an actual medical crisis.
Yes.
Because it limits the actual generalness or generalization of the trial findings.
Absolutely.
If you have patients who are Black in a trial in the single digits, how can you truly extrapolate the findings of that trial? We have to improve diversity in trial enrollment in this country to make sure we're providing care for that we understand works for everybody.
Right. So, and it's sad to think and terrible to think that we have all these ongoing trials, but because of the underrepresentation of the Black community there really is not a huge guarantee that what is being found to be really effective in these trials is effective in the Black community, because there's just not enough patients on trials to be able to effectively say, yes, it will work in the Black community as well as other communities, because we know that from the trial. So it's just so important that the population of clinical trials really reflect the population of the myeloma community as a whole, to be able to be the most effective trials they can be.
But there have been studies that have shown that several studies that have shown that African Americans fare as well as all other ethnicities in clinical trials and do not have more toxicities than other people in clinical trials.
Right.
So and there's a suggestion in some studies that actually African Americans with myeloma do better on standard therapy than other ethnic groups.
Right.
Yeah.
Right.
So that participation is something we can change today. We can change that today. And there's no better, safer, efficacious time than today.
So, okay. So I see that we're pretty much at the top of our hour. So I think that this has been, we've certainly heard a lot about precursor conditions, their symptoms, and how it is so important for patients to be educated and to go speak with their doctors about what they're feeling, how important it is to get a second opinion. If you have been diagnosed or you think that you might have a precursor condition, how important it is for patients to really be consumers of their own healthcare, and what a hopeful time it is right now for patients who have precursor conditions across the board, because since right now there is a lot actually happening in this field, as Greg pointed out, as opposed to what has happened in the past, many years of myeloma therapy. Finally, the field is really sort of catching up and moving backwards towards precursor conditions and saying, these are people that we also have to look at, and these are people that we also have to treat, especially in the Black community, because of the higher prevalence of these conditions and myeloma in this community. So I think everything's moving in the right direction. I think that we're in a very hopeful time right now. And I think it's great to have these conversations and just continue these conversations to be able to raise awareness of this disease, precursor conditions, and multiple myeloma in the Black community and every community. And I think that what happened with Colin Powell last week was a really amazing example of raising awareness in every community about what multiple myeloma was. I know, for example, our website just completely crashed that day because there were so many people saying Colin Powell had multiple myeloma, and what the heck is that? Right? So there were people who just had no idea what it was. We're really investigating it on our website, and I'm sure other places as well. So clearly awareness is key, and I think that these conversations are really so important. So on behalf of the MMRF, I'd like to really thank Dr. Craig Cole and also Amy Peer for being with us today on this really, really great conversation about precursor conditions in the Black community. I'd like to thank everyone who's watching for taking the time out of your day to watch us. And I'd like to ask those folks who have tuned in to complete a brief evaluation survey, and the survey link is going to be posted in the comments section if it's not already there. And finally, I'd like to thank the sponsors of this program: AbbVie, Adaptive, Amgen, Bristol Myers Squibb, Cure, Genentech, Janssen, Novartis, Oncopeptides, Pfizer, Regeneron, and Takeda Oncology for their sponsorship and for their support of this program. And I'd like to say that I know that we didn't get a chance to answer a lot of the questions that came in the chat today, but if you have questions that we didn't get to today, or if you have any additional questions about what you heard today, please don't hesitate to contact our patient navigators at our Patient Navigation Center. Phone number 673. And you can see that on our website as well, which is themmrf.org. So themmrf.org. So thank you everyone for tuning in, and have a great rest of your day. Craig, thank you. Amy, thank you.
Thank you. Bye, everyone.
Bye-bye.